Now are you able to see, right?
Yes, sir. Perfect.
Thank you.
Sir.
The concept should be provider queries. Okay. In syllabus domain 3. This is all the concept we can cover today. In this concept, you will get 10 to 15 multiple choice questions. This concept also we don't get in the book. If you understand the concept, then only we can able to answer that option. Okay. So you don't get in the book. So please understand the concept. If you have any doubt, please stop me immediately and ask it. Okay. Clear?
Yes, sir.
No.
Yes,
10
sir.
to 15 questions will come from this.
Yeah, 10 to 15 questions you will get in this concept.
Okay, sir.
So what is the meaning
Sir,
of query?
how much
First,
question? Sir?
10 to 15.
Marks, sir.
Marks means each
Each
multiple
MCQ, how
choice
much
question.
carries?
See,
Hmm.
each multiple choice question should be 2 marks, no?
Okay, okay. Okay, sir.
Okay. Each multiple choice question 2 marks. So all the multiple choice you will get 2 marks only.
Sir, we are not able to hear your voice.
Yeah, 1 minute, 1 minute.
Okay, sir.
Okay. Sorry, okay, 1 minute. Okay, small confusion. Yeah, thank you. So whoever joined the slow track and fast track, so please aware, this is the fast track group, okay? Whoever joined in the slow track, no, first freshers, you can join in the slow track. Only freshers you can join in the slow track, Pallavi class, okay? Here you can join all the people. So if I confused, no, because I shared 2 links, sometimes I confused. Okay, so do aware of that. Today only maximum, then it will be clear. Yesterday class I will share with everyone. So what is the meaning of query?
If there is any
What is the meaning of query?
if there is any conflicting in the document, we should ask the provider.
Communication between the provider. If a condition is having unspecified, we can ask for the specificity.
Then so who needs
The
It is
slow track?
communication
confirmation.
between the provider and the coder
Mhm,
to ask any questions or any
mhm.
Query
Then
means
clarification related to the charts and documentation.
any doubt, issue, or concern raised
Mhm.
by customer consumer.
Customer. Okay, no problem. Then
If the condition is only present in the HNP, we can ask in that cases if it belongs to CC or MCC.
mhm. Then
Query means
raising any question and doubt to the provider who has given the particular guidelines regarding it.
Mhm.
It may
Then,
be doubt or clarification.
okay, then. So you can tell me whatever your clarification now, because I will get idea whatever you know. That's why I'm asking this many times. Okay. Whatever you have idea about that, you can tell me, then we can discuss.
Sir, query is the communication tool between the provider and the coders and all, where we can ask them about any conflicting documentation, any query about any related diagnosis, types of that
Exactly.
diagnosis, like that.
Correct, bro. So query means communication tool. Okay. Query was a communication tool between the coder and provider to clarify any doubt in the document. To clarify the document. So when you will get the clarification, this is the exact definition. A position query is defined as the conflict, okay, communication tool used to clarify documentation in the healthcare record to achieve accurate code assignments. Okay, to proper code assignments, you need to use this communication tool. If you have any doubt in the document, you need to clarify the documentation issue with the provider. You need one communication, right? We should not send message directly. We should not mail directly to the physician. No? We need one process, how to pen the document, how we need to ask the clarification to physician. That communication tool should be query. Okay. When? Next. When we need to raise the query. Query is the communication tool between the coder and provider. Well and good. When we need to raise the query.
Conflicting diagnosis.
When there is a conflict in the documentation.
If document is
Conflicting in
not
the
clear, we can
documentation.
arise the query.
Lack of specificity.
Conflict
Yeah,
in
exactly.
documentation, if there is a criteria meeting, but the documentation is not documented.
Establish condition.
The condition like, for example, AK, we have a AK, but
Insufficient.
Tell me.
If the symptom is assigning as the PDX, we can query for the etiology.
Not like that. Then no, just I'm asking when we need to raise the query. Na, is there conflict documentation?
yes,
Okay,
Specificity documentation.
conflict. Then not
Clinical
specificity.
significant query.
Okay. Then
Any
incomplete
technical,
documentation. Incomplete documentation. Ambiguous or conflict documentation. Okay. Then when is there a issue in the record like facilitated, complete, or accurate, or consistent, timely documentation? In this time, we need to raise the query. Okay, incomplete, illegible, because unable to read the documentation. Illegible documentation, we need to raise the query. Okay, incomplete, conflict, illegible documentation. In these situations, we need to raise the query. Now, my question, documentation was perfect, but coder unable to understand the documentation. Okay, then we need to raise the query to provider or not. There is no issue in the documentation. Okay, there is no issue in the documentation, but there is issue in the coder side.
we can raise the
We can't query.
No. No.
We can raise the query or not required?
not, sir.
No.
Not required.
No. Okay. If there is need in the documentation, then only we need to raise the query to provider. If our side problem, like coder was unable to understand the document, they need to ask the supervisor. Okay. They need to clarify with supervisor. Directly, we should not send the query to provider. If documentation was clear, then we should not raise the query. Is there problem in the document? Then only we need to raise the query. Clear?
Yes, sir. Yes, sir.
Thank you. Okay. Always check the documentation need. Then only you can raise the query. So
Sir, a
based
small question, sir. If
Yeah,
the documentation is clear and the PDX also is given, PDX is there, but the criteria it is not meeting, then what we have?
is there problem in the document only, right?
Yeah, okay, sir. Okay.
If there is not meeting means it was a documentation issue, right?
Documentation, yes, okay, okay.
Is there any issue in the documentation? Then we should raise the query only. Next,
Okay.
type of queries. So please note down while raising the type of query. Okay, types of queries. We have total 3 type of queries: concurrent query, retrospective query, post initial billing query. Okay, concurrent query, retrospective query, post initial billing query. Clear? So first thing, concurrent query. When we need to raise the concurrent queries means when patient was staying in the hospital.
Patient is stayed in
Before
hospital.
discharge. Okay.
Before this, yes,
Patient
sir.
was still in the hospital before discharge. At that time, if you raise the query, it should be concurrent query. Clear? Who will raise the concurrent queries? Not generated by CDI specialist.
Generated with CDX.
CDI specialist. What is the meaning of CDI?
Clinical documentation
Improvement.
sir.
Okay. Clinical documentation improvement. Okay. The CDI workers now they will work for hospital side. Okay. They will work for hospital side. They will do in day-to-day documentation issue. They will directly contact with the physician and they will resolve all the documentation issue before getting the release of coding. Okay. Before discharging itself, they will resolve all the conflicting data in the record. So which means timely, most accurately, they will clear all the data issues. Okay. Then it will be easy for coding. If you are getting all the related conflicting data for the coding, it will headache, right? You need to send the documentation again to provider, again you need to get. It will take long time to complete a documentation. If they are resolved all the conflict data before releasing the coding itself, it will be easy for the coding. Okay, so the CDI specialist will work for hospital side and they will resolve all the clinic documentation issues time to time. Okay, before discharge itself.
Yes.
That type of queries should be concurrent queries. Next, retrospective query. These retrospective queries, when we need to raise patient discharged from the facility,
Yes.
but
Discharge.
before the claim has been billed, before the claim submission, patient left the facility. It should be retrospective.
Bro, listen first, please. Okay.
It should be retrospective query. Next.
Sir, can you explain it once again? I didn't get
Yeah, I will explain. So retrospective query means patient left the hospital while you are raising the query. Okay. Patient left the hospital. If patient stay in the hospital at the time of query raising, it should be concurrent query. If patient left the hospital while you raising the query, at that time it should be retrospective query. Suppose while you are raising the query, patient discharged from the facility. Then
Retrospective. Retrospective query.
query. So clear?
Yes, sir.
Next.
Yes, sir.
Post initial billing queries. Post initial billing queries. Okay.
So can you say retrospective second point?
Yeah. Are effective in cases where additional information is available in the healthcare in short stays or concurrent reviews was not completed or whenever a concurrent query process is not feasible. Okay, already concurrent queries are in process. Okay, at that time, if there is any additional report, okay, then also you can raise. Concurrent was not completed still. Like the coder was raised, the CDI specialist raised the query for query, but it was not resolved still. Patient already left the facility. Before the discharge itself, the CDI specialist raised the query. Okay, that query is still not resolved. But again, you have issue. You raise the query. Then also we can consider as retrospective.
Sir,
So that means
exactly,
concurrent query
exactly.
already is in process.
Yes, yes.
So, can I ask, sir?
Yeah.
Yeah, concurrent query already is in process and patient discharged. So it is in process. That's why retrospective query is needed at the time. Am I right, sir?
Exactly. Why? Because na, if
Okay,
left the
sir.
facility means that query should be retrospective, no?
Okay, sir. Got it, sir. Thank you.
Sir, can you explain who is the responsible for that retrospective query and concurrent query?
Response from
Responsible persons for that
physician, always physician, right?
CDI only,
No, physician.
physician, and for concurrent CDI.
Everyone physician only. See, 1 minute, I will explain first thing. So next, post initial billing query. So post initial billing query means after the billing, after the claim submission, if you raise the query, it should be post initial billing query. Okay. If you raise the query after the billing, it should be post initial billing query. Like we can use this up to 12 months from the discharge date for non-Medicare accounts. Up to 12 months, we can use this post initial billing query, but you can remember at least concurrent and retrospective. These two enough. This post initial billing queries we should not get. It was very rare. You will get only retrospective and concurrent. Now, come. So, concurrent means who will raise the query? CDI specialist, right? Retrospective, who will raise? Na? Coders, medical coders. Okay, for whom we need to raise the query? Now, always remember to attending physician. Always we need to raise the query only for attending physician. Always raise. Only attending physician. We need to raise the query. Either coder or CDI specialist. Whenever you have doubt, we need to ask the physician only. Attending physician only will resolve the issue. Okay. Now, my question. What is the difference between attending provider and other treating providers? Attending provider and other treating providers. What is the difference?
Attending provider is the provider who has seen the patient. He has treated. Other treating are who are there in the hospital or
Then any other?
They are referred by the attending provider, other treating providers.
Attending provider means the main physician who will be responsible for all the treatment procedures and all things. And other providers means like any specialist, any provider who is staying with the attending physician. Like
Good, bro. Attending physician means who was admitting the patient in the hospital, okay? Who are admitting the patient in the hospital. That physician should be attending physician or admitting physician. Whoever come to the hospital to see the patient like consultant, radiologist, nutritionist, pathologist, these all are other treating providers. Okay, suppose if patient was stayed 10 days in the hospital, 10 days. So one patient admitted. Day two, one consultant come, nephrologist and urologist they come, and the pathologist will come and they take the sample and they will give. Radiologist will come and they will give their report. So all the reports summarization, who will provide? Who will summarize the all the data? Attending provider only, right?
Yes.
Yes.
So he was the owner of the patient. He was the responsible of the patient. Suppose radiologist came and they given their data. That data compulsory attending patient must review and confirm. No?
Yes.
If pathologist came and they given their impression, that was confirmed or not, again attending patient must be reviewed. So that's why always we need to confirm with attending patient only. Is there any conflict in the document? Okay, we need to raise query. Always remember only for attending physician. Clear? Always raise query only for attending physician, not other providers like consultant, radiologist, nutritionist, pathologist. We should not raise the query. Is there document conflict anywhere in the record, either radiology note or pathology note or consultation note? All about the notes, we need to raise the query only for attending physician. This is the first point, remember. Either CDI query, concurrent query or retrospective query. Both queries we need to raise to attending physician only. Clear?
Sir, I have a doubt.
Yes.
Attending provider, if there are two providers, like for the first provider and he transfer the case to the second provider, in that also who admits the who admits the patient, that he will become the attending provider only, right?
Exactly.
Ah.
Sir,
Yeah.
what is the difference between attending provider and primary provider?
Primary means?
In documentation, it will be there, sir, sometimes.
Primary
It's
only attending
same
first
or
physician. Primary only attending physician only. Okay? We
same
don't have
only.
same meaning only. Either
Okay.
primary or attending provider or admitting provider, attending physician, admitting physician, all are same meaning only.
Okay, sir.
So
No.
there are many providers will see only one patient, right?
Yes.
So
Many physicians
when a
will
provider
see in that who admitting the patient in the hospital, that should be one physician, na?
at first time.
Yes. When at the time of admission, who was admitting the patient to
Mhm.
the physician, that patient should be admitting physician or attending physician. Remaining
So
all
in the middle of
physicians
the
should be
days,
in middle of the days who check the patient, that all the patients should be other treating providers.
okay,
That only
sir,
I'm
if
saying, right?
one
Like
provider if admit
consultant,
attended,
radiologist and all. Yeah, tell me. Go ahead, bro.
okay, only admitting provider will be admitting. So remaining other consultant, progress and pathology radiologists will comes under other treating providers.
Exactly, that only I'm saying. Okay. So
Am I right, sir?
wherever the other treating providers, like whatever said, consultant, radiologist, pathologist, is
Mm-hmm.
there any issue in this related document also? We need to ask only admitting provider or attending provider. We should not raise the
Okay,
query
suggestions will
other than attending provider. No one. Only raise
okay,
attending
suggestions will
provider.
goes to the attending provider at last.
Exactly. Because attending
Okay.
provider was the owner. He need to summarize all the records. Either consultant, radiologist, or pathologist, or progress notes. They need to give their summary at the ending. That's why he was the main person to confirm the diagnosis.
Yeah, okay, sir.
Now you get idea, right? Always raise query only for attending physician. Don't raise the other treating providers. Now you get idea about concurrent query.
Yes, sir.
Retrospective query. Correct? These concepts clear, no?
Yes, clear, sir.
Yeah. Now, in the document we discussed, right, incomplete, illegible, inconsistent, and all. So, what type of queries we need to raise based on the documentation issue? Based on the documentation issue, we can raise different type of queries. One concept we can discuss. Okay. First concept should be conflict between admitting provider and other treating providers. Either diagnosis or procedure. Diagnosis or procedure related. Conflict between the admitting provider and other treating provider. When we can get the conflict between the two physicians about diagnosis or procedure? When we can get the conflict between two physicians about diagnosis or procedure?
When
When they
HNP
both
or
give
the
different
documentation
diagnosis or
Exactly. Both are giving different
different
diagnosis on the same point. Okay. They are not getting the conclusion about the diagnosis. They are given different summary. Okay. Suppose a patient coming with renal mass. Okay. Or liver mass. Okay. Coming with mass, they taken the sample and they sent to path report. Path report. Pathologist. Now, pathology documented carcinoma. Attending patient documented liver mass. Now, pathologist documented it was not a mass, it was a carcinoma. So, can we quote directly from the pathology report carcinoma?
No.
No, sir.
No, sir.
No.
No, sir.
Pathology was not a valid provider, correct?
Yes, sir.
Yes, and here conflict. We don't know it was mass or carcinoma. If we go with mass, carcinoma was more severe condition. If we can quote directly without attending patient review, it should be problem. If attending patient said again, it was not a carcinoma, it was a mass only, then problem, no? At that time, we need to confirm with attending patient about pathology report. Pathologist documented adenocarcinoma, please confirm it was mass or adenocarcinoma. Clear? We need to confirm with attending patient, is there any conflict between the other treating provider? Either documentation
Sir,
wise
can
or
we go on say again,
diagnostic
please?
or procedure wise. Tell me.
Can we go on say again, please?
No problem. Lot of examples we can discuss.
Thank you.
Next, suppose nephrologist documented renal fail. Nephrologist documented renal failure. Okay, attending patient documented renal mass. How we can code the documentation? We need to code renal failure or renal mass.
We need to keep conflicting query.
Here also conflict, no? We don't know
Yes.
which one is correct. So whatever the documented nephrologist was consultant. Nephrologist means consultant. So whether the consultation document correct or attending patient review correct, we don't know. At that time, we need to raise the query to whom, either nephrologist or attending patient.
Attending physician.
Attending physician.
Attending. Only raise the query for attending physician only. Do not raise the query for nephrologist or nutritionist, consultant, anything. Always raise query only for attending provider or attending physician. That's it. Okay. Any conflict between the two physicians, like attending provider and other treating providers, we need to raise the query only for attending patient to clarify the documentation, either diagnosis related or procedure related. Clear?
Yes, sir.
This concept clear, right?
Sir,
Any
can you
doubt?
say first one, sir?
Sir,
Mass sample.
Same. Suppose attending patient documented liver mass, pathologist documented liver adenocarcinoma. What we need to code here?
So the conflicting
Yes.
queries.
Conflicting,
Query.
right? We don't know mass or carcinoma. Then we need to query about pathology document. So please confirm pathologist documented adenocarcinoma. It was carcinoma or not? That's it. No?
Okay, sir. Got it.
Sir,
Thank you.
can you please give example on procedure also? One example.
Any issue like in the procedure note also. Okay. So they are not documented complete procedure. At that time also if you raise the query. Or
Oh.
they are documented different things in the procedure note. Then also we need to raise the query.
Oh.
Next. This concept clear na conflict between the two providers.
Yes, sir.
Yes, sir.
Next
yes, sir.
query, acuity or specificity query. Okay, acuity or specificity query. See guys, first thing remember, these queries we are raising only in inpatient coding. This acuity or specificity query, remember, do not confuse. So, whenever you are find any unspecified diagnosis while you are working in outpatient, like ED, surgery, HCC, can we code directly unspecified diagnosis, right? Suppose if you see assessment CHF, can you code or not in outpatient?
No, sir.
You are not coding in outpatient.
Yes,
Outpatient we
coding.
can code, sir.
Yes, sir.
That's only I am asking.
Inpatient we can't code.
I am asking
Inpatient.
outpatient, then why you are worrying about inpatient? So, listen carefully what I am asking, for that you can answer. Then it will be easy for us. So, if they documented one unspecified diagnosis like CHF, CKD, unspecified stage, pneumonia, and all, or respiratory failure, whatever it may be, can we code directly from the documentation, right? Unspecified code can we code, na? Like you are working in outpatient or HEC coding.
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Yes, right? So we can code I50.9. But
Yes, sir. I50.9.
yeah, but while we are working in IP-DRG coding, if you are working in IP-DRG, if you find in the documentation one unspecified code, but for the diagnosis you have more specific codes in the ICD-10-CM index documented, but ICD-10-CM index have more specific type of codes for same diagnosis. At that time, we should not code unspecified by default in a inpatient coding. We need to raise the query for specificity or acuity of the particular condition. Okay, we need to ask the please provide any specific documentation, the type of the diagnosis documented or not. Okay, we need to raise the query for specific type of diagnosis. We should not code unspecified in inpatient maximum. We should find the specificity. If there is no specificity in the record, we need to raise the query for specificity. Okay? We need to raise the query for specificity. For example, if the documented assessment, respiratory failure, we should not code respiratory failure by default. Need to raise the query for type of respiratory failure. type of respiratory failure. What are the types we have, like acute or chronic or acute and chronic? Please provide the type of respiratory failure. Okay. Like suppose they documented CHF. We need to raise the query. Please provide the type of CHF. If they documented CKD, please provide the stage of CKD. If they documented pneumonia, please provide the type of pneumonia. We need to ask the type of specificity about the condition. It should be called acuity or specificity query. Specificity query means do not code unspecified diagnosis in inpatient. We need to raise the query for specificity of the certain diagnosis. If they're not documented specificity in the record, we need to raise the query for specificity. Okay? Clear?
Sir,
Yes.
is it applied for only acute specific codes conditions or CKD or like that also?
Anything like chronic kidney disease also, we need to raise the query if they're not documented stages.
Okay, sir.
Not acute or not chronic. For the diagnosis, have more specific types. But they documented unspecified in the record. That's it. Clear?
Sir, can we query for that hypoxemia and hypoxemia like that?
Related? Like if
Respiratory.
they documented respiratory failure with hypoxia or without hypoxemia. For diabetes, why we need to raise the query? It was default guideline. No? If they're not documented type of diabetes, go with type 2.
Not for diabetes, sir. For respiratory failure, they
Yeah,
like
we need to raise. Actually, I seen message. Actually, we need to raise the query. Like if they said acute respiratory failure, you are asking.
yes, sir. But they didn't mention that hypoxia any.
Then no problem. We have direct code now without hypoxemia. Okay, acute respiratory failure enough. It was a specificity.
Okay, sir.
No need to give with hypoxia, without hypoxemia and all. The type documented acute or chronic respiratory failure, that documentation was specificity.
That is only enough. No need to
That's
that.
it. No need. Suppose if they given like viral pneumonia, aspiration pneumonia, that's enough. If they given CKD 2, 3, enough. If they given specificity, any one specificity, enough. Okay? Clear?
Okay, sir.
Sir,
Thank you, sir.
but in CKD unspecified is mentioned. You can raise query about specification also, no?
Yes, stages we need to raise the query. That only I am saying. No? Stage for CKD stage, you need to raise the query. Okay? Which stage, please provide.
What about neoplasm? If it is not mentioned, we have to take it as primary only, or whether we have to ask query for that also.
When we need to raise, tell me. Give me one
Like
example.
neoplasm cases, if they just
Yeah.
mention neoplasm of liver or something.
So here, first remember, in neoplasm cases, first, we need to check. They documented multiple neoplasms or single neoplasm. Okay? Multiple or single neoplasm, like one neoplasm. Clear? So now tell me, in your question, they documented multiple or one neoplasm?
Single.
Single. Then by default, it should be primary, right?
Okay.
When they documented multiple neoplasms, okay? They documented multiple, like 2 or 3 neoplasms, they documented. But they not documented what is the primary. Documented. But no documentation for the primary site. At that time, we need to raise the query for metastatic to or metastatic from. What is the primary site? Clear? Huh?
Yeah.
When they documented multiple neoplasms, but they're not specified primary or metastatic, then we need to raise the query. If they documented only one neoplasm, no problem. Default, it will be primary. If patient have one site, it should be primary site only. Whenever patient have multiple sites, but they're not documented. What is the primary? What is the secondary? At that time only we need to raise the query. That query should be, we need to ask, please provide the primary site. If they provide primary, remaining all should be metastasis, correct?
Yeah.
If you know the
That
primary,
was
then all should be metastasis, right?
no, that was
Simple.
my doubt.
Yes,
If they give one specific location, how to consider it? Yeah, it is clear.
That only I'm asking. We need to raise the query. If patient have only one neoplasm, no problem. Single neoplasm, that should be primary default.
Okay. If they
Whenever
mention
they
secondary
documented,
neoplasm,
I didn't get you.
no, if they mention secondary neoplasm of liver and they don't mention the primary site, then
We
that
have
time we have
guideline.
to.
Na? Primary should be unspecified. We need to code.
Okay.
We have that ICD guideline, right? Whenever metastasis neoplasm, primary not documented, we can go with unspecified primary. Okay. Whenever they documented multiple neoplasms, but they not documented site, at that time only we raise the query in neoplasm cases. Thank you. Now you get idea about acute or specificity queries. Simple. If they documented unspecified condition, but diagnosis have more specific types in the ICD book, raise the query for specificity. Clear?
Yes, sir.
Next, laterality query. What is the meaning of laterality?
Right side or left side?
Right.
Exact side.
So right or left, correct? Conflict between right or left. Left. Like in the same diagnosis, they're saying one place right, one place left. Header states right, documentation states left. For example, they take an X-ray for right hand. Same X-ray report right hand, impression said left hand pain. Can we able to code this left hand pain?
No.
No, sir.
No.
Because
No.
if they done right side X-ray, how they can find left side diagnosis, correct?
Yes.
Yes.
Is there somewhere conflict whether diagnosis should be right or procedure should be, sorry, X-ray should be right or diagnosis should be left? We need to check. Okay, then same concept. They said diagnosis like yeah, fracture right radius. Okay, fracture right radius. Then procedure done for left radius. They done fracture reduction for the left radius. Documented in the operative note, fracture was reduction for left radius. In the impression diagnosis said patient have fracture on the right radius. At that time, how we need to code?
You need to raise query.
We need to raise the query. Okay, because we should not code diagnosis one side, procedure other side. Clear?
Yes, sir.
Yes, sir.
So,
Yes,
is
sir.
there conflict between the right and left? Somewhere they are saying right, somewhere they are saying left. At that time, we need to raise the query for laterality. How you will get the question now? They will give like physician document coming for the mastectomy of the right breast. Physician done the mastectomy and they send to the pathology report sample. Attending pathologist documented left breast adenocarcinoma. Same left breast adenocarcinoma documented in the discharge summary. How we can code? Admitted for right breast mastectomy. They done mastectomy right side. Discharge summary documented left breast adenocarcinoma. How we need to code this scenario, whether procedure has opposite side and diagnosis opposite side. We should not code, right?
To raise query, sir.
To raise query.
Conflicting queries. We
You
can
want to
raise.
raise query.
Raise the query. Like which one is the exact site, either right or left. We need to check. How we will get the options now? This type of query, they will give option like code both as right, code both as left. Otherwise, code diagnosis as per the right, procedure as per the left, or query for laterality.
Query for lateral.
We need to raise the query for
Lateral.
lateral. You will get in this concept 1 or 2 questions. Okay, diagnosis one side, procedure one side. They will document. Okay, at that time we should not assume by default both as right or both as left. We need to find the exact site, right or left. We need to raise the query for laterality. Clear?
Yes, sir.
Thank you. Next concept, cause and effective related query. Cause and effective related query. What is the meaning of cause and effective relation?
If there's a cellulitis and diabetes, if there is no relationship mentioned provider, we should query for provider. Is there any cause and effective relationship between cellulitis and diabetes?
Good. Then cause and effective means simple term. Okay, no need example. Tell me what is the meaning of cause and effective.
Etiology and manifestation.
Etiology of the diagnosis.
Etiology and manifestation. Whenever patient have two diagnoses, okay, that was related to diagnosis, they documented. Maybe chances the diagnosis developed due to underlying diagnosis, but they not documented properly. Okay, at that time we need to raise that underlying diagnosis was developed due to the another diagnosis or not. Okay, same whatever you said. Patient have DM cellulitis. We should not code by default linking, right? These two. We should not assume by default linking. No? This cellulitis was not under the fifth term. By default link, we should not assume between diabetes and cellulitis, correct?
Yes.
Yes, sir.
If they not documented that cellulitis was unrelated to the diabetes or related to the diabetes, at that time we need to check the relation. If that cellulitis was related to diabetes or not, we need to raise the query. We need to get the confirmation. Okay, then patient have sepsis. Listen, in this concept you will get one question, sepsis related. Organ failure. How we can code?
Need to see relationship between organ failure and sepsis. If organ failure related to sepsis, then we can give combo codes.
Severe.
Severe sepsis.
Severe sepsis.
Severe sepsis.
Severe
Yes.
sepsis.
Severe sepsis. We need to query, sir, that organ failure will be sepsis or not.
Good. So first thing, whenever they documented sepsis and organ failure, we need to check for the relation. Check for relation. Organ failure due to sepsis are unrelated. Okay. Organ failure related to sepsis. Code sepsis, severe sepsis, organ failure. 3 codes you will get. Okay. If they documented organ failure unrelated. Organ failure, unrelated to sepsis. Then code, sepsis, organ failure. Okay. Code only sepsis and organ failure. If they clearly documented, organ failure was unrelated to the sepsis. Code sepsis and organ failure. If there is no relation, they're not documented, it was related or unrelated. Just the given sepsis and organ failure. They're not documented relation between the two conditions. At that time, query for relationship. This is the cause and effective relation. Okay, we need to raise the query that organ failure was due to sepsis or unrelated. We need to raise the query. Clear?
Once again, sir.
So simple. If patient has sepsis and organ failure, first you need to find the relation between the two conditions they documented or not in the record. If they documented clearly, if it was related to the sepsis, code sepsis, severe sepsis, organ failure. If they clearly documented that organ failure unrelated to the sepsis, code sepsis and organ failure. Don't code severe sepsis. If they're not documented, it was related or unrelated. They documented simply organ failure and sepsis. At that time, raise the query for relationship. Clear? Clear? Huh?
Yes, sir.
So,
Yes, sir.
yeah. We need to check the relation between the organ failure and sepsis. That's it. If they document a relation, as per the relation, you can go. If they not documented any relation, raise the query. Next concept. Same question, sepsis related only. Patient have sepsis, local infection like cellulitis or pneumonia, any local infection, and post procedure. Like they done procedure recently. How we can code the sepsis? They not documented how sepsis was developed. Just they saying patient have local infection and post procedure also done recently. They done one procedure. Now they
Query.
came to sepsis.
Query. Sepsis cause.
Query.
We need to raise the query for sepsis here. It was due to local infection or due to the post procedure.
Post procedure.
Because we have two options, right? Maybe chances to get due to the post procedural sepsis also or local infection also. So at that time, we need to raise the query. Relation, it was due to post procedure or due to local infection. We should not assume by default, okay? We should not assume by default it was due to local infection or due to procedure. We need to raise the query. Okay, need to raise the query. Please provide the relation between sepsis and local infection. If it was related to local infection, go with sepsis. If it was related to the procedure, go with post-procedural sepsis. Clear? Huh? We need to check the relation. Like this, whenever the chances, like the diagnosis was due to underlying diagnosis, may be developed. If they're not documented clearly, we need to raise the relationship between the two conditions, cause and effective related query. In this concept, we will get sepsis related question. Remember these two concepts, sepsis and organ failure related and sepsis, local infection and post-procedure related. Okay. Clear?
Yes, sir.
Yes.
Sir.
Yeah.
Thank you. Now, we covered acuity query, laterality query, attending provider and other treating provider query, and cause and effective related query. Next query should be important clinical indicator query. This is the important concept in inpatient. So first thing, remember, just wait 2 minutes, everything will listen. Okay. But whoever already know, no, just listen silently. Because if you tell answers, no, they will confuse other people. So while we are working in outpatient, if you found symptoms, what we need to go do? There is no diagnosis, just the documented symptoms. We can code the symptoms as per the documentation, right?
Yes.
You should not worry about. Suppose they coming with cough and assessment also documented cough. Can we code cough, right? That's it, no?
Yes.
Suppose patient coming with abdominal pain. Assessment also documented abdominal pain. There is no diagnosis. We can code abdominal pain, right?
Yes.
Yes.
Suppose. Or they done one X-ray. Okay, chest X-ray they documented. A patient have SOB. Medication they given Lasix. Can we code SOB or can we code CH? If they're given the treatment but they not document the diagnosis, can we assume the diagnosis based on the treatment?
No.
No.
No,
No.
right? As per the golden rule, what they
No.
documented, that's it, right? That's only done. Correct. Whatever they documented in the record, that only done. We should not assume anything other than the record. Correct? Whatever
Yes,
they
sir.
documented, that's done. We should not assume by default ourselves. If they're given in the medication, insulin, if they're not documented anywhere in the record diabetes, why they will give without diabetes insulin, we should not assume and code diabetes. Okay, if they documented diabetes, we can code, otherwise we can leave. That's it, correct?
Yes, sir.
Yes.
But while we are working in inpatient, okay, while we are working in inpatient, they not documented the diagnosis, but they given the related supporting data about the diagnosis in the record. Here also we should not code diagnosis, but we need to raise the query for diagnosis. Okay, we need to raise the query for the diagnosis based on the indicators and clinical evidence. We should not raise the we should not code the diagnosis in inpatient also, just we need to raise the query about condition. Okay, so simple. Clinical indicators means clinical indicators are nothing but sign and symptoms, diagnostic or therapeutic options, or therapeutic options of a particular condition. Okay. If then given the diagnosis or treatment option or symptoms of the related diagnosis, we should assume the diagnosis based on the indicators and you need to raise the query. We should not code in inpatient also based on the validation, but you need to raise the query. Okay. It should be clinical indicator query. Suppose if they documented one symptom, can you assume the diagnosis? If they documented one,
No.
no. So minimum of SCA requires a minimum of, so how many indicators?
Okay.
Two. Depends on the process. Okay, some people will follow the 3 indicators, some people will follow the 2 indicators. But in exam point of view, you will get 3 indicators. Okay, exam point of view, you will get minimum 3 indicators. Depends on project. Some people will follow 2, some people will follow 3. But exam point of view, remember, you will get all questions. They will provide 3 indicators minimum in the question. Okay. So now listen carefully. You need to remember the clinical indicators of the diagnosis. Okay. You need to aware of these clinical indicators. I will share these clinical indicators with you. Okay. You need to learn about the clinical indicators. Okay. But not all the diagnosis, only 5 to 6 diagnosis enough. I will tell the diagnosis and I will share the documentation. Now you can note down the diagnosis names. Later we can read the indicators. So please note down acute blood loss anemia. Acute blood loss anemia. I will share this record with you. So note down acute blood loss anemia. Later we can discuss the indicators, like you need to read the indicators and all. So next, note down types of encephalopathy. So you need to get this type of encephalopathy: metabolic, toxic, septic, toxic, metabolic. You need to aware of these types. Okay. Types of encephalopathy. Then heart failure. Heart failure. In this concept, you will get 2 questions, guys. Heart failure. Okay. Heart failure. They will give like B patient have BNP, SOB, and this LASIX. For what condition you will raise the query. Okay. Otherwise, they will give medication. Sometimes they will give edema, BNP, SOB. Then also we need to raise the query for CHF. They will give based on the ejection fraction. Remember these ejection fraction values. Based on the ejection fraction value, we can raise directly query for systolic or diastolic. Okay. Aware of this ejection fraction values also. Here also one question you will get based on this ejection fraction value. A patient have 35% of ejection fraction. What type of query will raise for CHF? We can raise the type of all CHF or systolic CHF.
Systolic CH.
Only systolic enough, because based on the ejection fraction itself, we can identify it should be systolic. So note down heart failure. Okay. Later we can read these indicators. Okay. In your free time, you can read. Maximum we need to learn about 5 diagnosis. Sepsis. Next should be sepsis. In this concept,
I
one question.
I guess somebody's mic is on. It is disturbing.
I will close. So next we can note down sepsis related. Okay. Sepsis related, you can note down the condition, then we can discuss. Sepsis. Okay, here one question you will get in the sepsis concept. Because here lot of diagnosis we have, that's why I'm asking you to note down the conditions. Okay, sepsis. Next, you can get hyperkalemia. Hyperkalemia. Note down the diagnosis name. Hyperkalemia. Next, aspiration pneumonia. Aspiration pneumonia. I will share all the indicators in the group with you. You can by heart the list of the indicators for each diagnosis. Suppose if you found any 3 indicators related to the particular diagnosis, we need to raise the query for diagnosis. We should not code, we need to raise the query. Clear? After the session, I will share that indicators list in the group. Go ahead. Okay.
Okay, sir.
Now, whatever you have doubts, you can ask me. I will